All right. Welcome, everybody. Thank you so much. Sheila Brandenberg
Welcome. Thanks for inviting me.
Yeah. Sheila's joining me for a conversation today because here at Met How at Home in our Get Ready campaign, we're talking about caregiving and fall prevention in the next 2 months. And when I think about care in this valley, you come to my mind straight away. And so I wanted to just have an opportunity to dive a little deeper. Sheila and I have been working together on an advanced care planning initiative for the last couple of years, and we certainly refer folks to you, who are in need of palliative care. So we'll be hearing more about the Okanagan Palliative Care Initiative today. But I also, big part of Met How at Home is just to get to know each other better and to know each other and to be known. And so thank you so much for agreeing to do this.
Oh, you're welcome. I'm very honored to be here to answer questions and get to know each other even better. And
So I wanted to start with just some of your formative people in your life, because you're such a giver. And, usually behind everyone who has chosen that life of service is our inspirations. And so I'd love to start there and just hear about.
That's a great question. So my parents are my inspiration. They grew up in a kind of hard scrabble life in the Midwest and back on the Eastern Coast. And they met in high school, got married early, had babies early, and really fought for creating a life together. They moved to Colorado, and from Colorado, they moved out to Oregon when my older brother and I were just infants. And my dad was an entrepreneur. He developed a business in upholstery and did that for about 40 years. Also was a real estate developer, doing rentals and property like that. My mom, she was a servant leader. She really supported my dad and did whatever it took to help him. And when I was in high school, she actually went back to nursing school and became an LPN, which was a lifelong dream of hers.
All right.
And they were very instrumental in our small rural community in Eastern Oregon.
Where was that?
Pendleton.
Oh, okay.
Yeah, that's where I grew up.
I'm learning already. I didn't realize you grew up in Pendleton.
Yeah, we moved initially from Colorado to Bend, Oregon, and then from Bend we moved to Pendleton, which is where my dad developed his business. And I grew up and graduated from Pendleton High School. And I had two brothers, and my mom and dad both volunteered for Kiwanis and Eagles and Elks and the Sophomores and just about anything related to helping our community. So really had great role models.
That's wonderful. I know. Yeah. Are they still in Oregon? Are they still alive?
Yeah, my mother lives on the Oregon coast.
Oh, okay.
And she and my stepfather are retired. He was a CFO of a small rural hospital.
Oh, wow.
So, and they married when I was in high school. So I've known him for a very long time. And my father passed away from Parkinson's in 2015. Parkinson's and Lewy body disorder. So, I've walked the walk that many of my patients walk, you know, dealing with really difficult disorders and prognoses.
Yeah. Well, thank you for just continually showing up, for people in all different ways. And that is my next question, is just to talk a little bit about just the trajectory of your career and some of the experiences that drove your evolutions and your changes and along the way.
Yeah, it was, this is a great question of reflection for me of kind of where I've been and where I came from. Again, I grew up in a really small community, and my first real job at at 15 was I was a nurse's aide in a nursing home. And I loved that opportunity. You know, back then we were like little candy stripers and we didn't have real jobs. But one of my jobs was I was the shower aide. And that meant I took people from their rooms to the showers and back and helped. And I really did a lot in the building, just kind of being with the elders that were in the building. And what I really discovered very early on is there had to be a better way to take care of people than the way it was being done. And it wasn't like people were being abused or harmed, but it just didn't feel good.
Yeah.
You know, back then you like had to wrap people in a towel and take all their clothes off and whip them down the hallway to a big cold room. And it just, you know, a lot of angst for patients.
Right. Yeah. That institutional feeling.
Yeah. Yeah. And so that's kind of where I started in the healthcare journey. I knew my mom always wanted to be a nurse. She always used to, and I guess I'll share this little story. She always used to tell me as a child that I would never be a nurse because I had a very sensitive, like, if I touched something that was squishy or, you know, got really nauseous. And so it was funny. So from Pendleton, when I graduated from high school, I went away to Klamath Falls to college. And I had no idea really what I wanted to study. Initially, actually, if I step back before that, I had planned to go into the Navy. I wanted to go into communications with the Navy because I didn't have any funds to go to college.
Right.
And so I thought that would be a great way to get education. And that fell through. So I found out I was a sleepwalker and they wouldn't take me in the Navy.
Oh.
Yeah, and so I went to Klamath Falls to college and started studying medicine. And then from there I moved to Spokane, Washington, and was accepted into the nursing program. And really found that was the route that I really wanted to take. My husband at that time was in construction, and he talked about moving from Arizona to maybe Colorado. And I thought, you know, that would be a great job because I can move everywhere. And,
absolutely.
Yeah. So went into nursing, kind of as an aside. I started working
despite your aversion to squishy stuff.
Despite my aversion, I'm still averse to squishy stuff. But I'm really good at hiding it in front of people. And so from graduation, I went into long-term care for a while. I worked in a subacute facility, did a lot of home care with infusion and children. And I took one job working in a hospital, and I lasted about a year. It just wasn't for me. I didn't care for that institutional. I guess I like to be a little more free and on my own. So my trajectory from there has always been sort of in that vein. I did children, I did infusion therapy, I did subacute therapy in Seattle up on Capitol Hill. And then I worked for a company that did long-term care consulting with nursing homes throughout the state of Washington. So that kind of set me on an administrative track, doing more administration and a little less work. I'm hands-on. And then I met my now husband, Daryl, and moved to the Methow.
What year was that?
That would be in 2006. Yeah, 2006? No, that's not right. 95, 2001.
Right.
2001. Yeah. No, that's not right either. See, I can't do my math in my head. So we moved here in 1999.
Yeah.
That's right. 1999.
Yeah, I got here in 2000, and I think I can remember hearing your name from the beginning, kind of. Yeah.
So then I worked for that organization for a year, and then I switched over and worked for Okanagan Palliative or a hospice over in Okanagan, and I ran the Twist branch for quite a few years. I worked for them for 10.
Oh, I didn't even, is there still a Twist branch?
Mm-mm.
No, I was going
Yeah.
to say
No,
that
they
does
closed
not
it.
exist anymore.
Mm-mm. No, it wasn't economical after a while to have an
Right,
office in every city. So they
right,
closed them all down and brought them all to OMAC.
right,
Yeah.
right. And then you worked on starting Jamie's Place.
Yeah. So yeah, in 2006, Glenn Schmeckel called and said he had a proposition for me, and so he was talking about this philosophy and opening an adult family care. And as a nurse traveling around Okanagan County for home health and hospice, I saw adult family homes, and I thought it was a great way to keep people out of nursing homes and keep them in a smaller home environment. But it wasn't quite an exact match for me.
Mm-hmm.
So we had kind of talked about it, and he said, well, I have this place. I want you to go with me on a trip to California. We're going to go talk to these people about this thing called the greenhouse model. And I had never heard of such a thing. So I did a little research, and we flew off to California. And at the end of their 1 hour presentation, I was sold. The greenhouse model is person-centered care. So it puts the person in the middle of all care decisions. What they want to do each day, how they want to sleep, when they want to get up, when they want to eat. They get to make decisions. And traditional skilled nursing facilities, which I've been in a lot of, they're very structured. Everybody gets up at the same time. Everybody eats at the same time. Everybody goes to bed at the same time. There's not a lot of individuality.
Right.
So I said yes. And at that time, there was no building.
Right.
There was nothing. And so the whole process of starting Jamie's Place was really just creation and initiation and figuring out how to hire staff and how to set that all up. So that really has been, up until palliative care, that has been my major project, and really a passion of love to put that into place.
It is, yeah, remains so integral to the community now. It's hard to imagine that it wasn't here, you know. Thank you, Sheila. Thank you, Glenn.
Yeah, absolutely.
Yeah, so that's my next question, just about what your role was at Jamie's Place. It sounds like a lot of it was getting it going, getting it set up, and just some of the things that you learned from your experience there.
Yeah, so it was a lot of learning for me about setting up policies and procedures and working with the state and, administering and being the director and also being the nurse. So I was kind of doing it all. And some of the things that I really learned there were, one, I learned that I love and everyone should experience person-centered care. That is the way we should be taking care of our elders. They should be the center of decision making. I learned that being in an environment of person-centered care really was the answer to the question I asked when I was 15, is why is there not a better way? And so it was just such a full circle kind of experience for me to be able to take care of people in that way, to know everything about them, to be able to celebrate everything they loved in life or the way they liked different things,
Yeah.
The staff that I hired, I got to watch these people grow from, many of them had never been a caregiver before, and to become really great caregivers. And if you go to Jamie's Place now, the staff, Jessica is one of them. I mean, just amazing transformations and just beautiful, amazing, caring people. And so many of those experiences just like that.
Yeah, what do you feel like makes a great caregiver?
Being curious.
Yeah.
Being able to kind of set boundaries for yourself about kind of how life works and why you do what you do. And being willing and able to share yourself with another person. So, when you're working with the elderly, particularly if they have dementia, anything can be said or done in a day, and you just have to learn to roll with it,
Yeah.
and learn to have fun. And I ask great questions, because that's where you get really great stories,
Right.
and
Right. That's that curiosity,
Yeah.
leading with the curiosity
Yeah.
instead of like thinking that we know
Exactly.
the best.
Exactly. And these folks, oftentimes they didn't understand what was really going on to them and with them and in their environment. And so you find that you have to learn to be really patient and calm and set all your stuff outside the door and not bring it into the building, and being open to learning. And many of those elders really do have a lot to learn. I mean, have a lot to teach us.
Oh, yeah.
And so, we all learn a lot when we work with elders. Yeah.
Yeah. I just love that it's growing, that Jamie's place is continuing on and growing and
Yeah, it's pretty exciting.
Evolving.
It's kind of like stepping back and watching your children become adults. You get to step back and go, yeah, I helped work with that.
Yeah.
Yeah.
Absolutely. Yeah, so that's an interesting boundary, that like knowing your own personal boundaries and then also having that curiosity. And so I'm wondering if any of that rolls into my next question, which is about that, you've been holding space for people at the end of their lives. And that's a real art to continue to show up at those moments, because it's not only about the individual having that experience, but the family having that experience. And so I'm curious what you've learned, from people who are in that really vulnerable place.
Yeah. I think, it's an interesting, I look back and I never made a concentrated effort to spend my life at the end of people's lives. And, people often will tell me that is a really hard job. I don't know how anybody could do it. But there is a lot of joy and passion at the end of life. And you get to really see people struggle, but also succeed with something that we all have to deal with, whether we like it or not.
Yeah.
And what I think some of the things that I really learned from my patients, my families, my staff was, don't wait. Don't hold back on things. If you have something to say or a relationship to fix, do it. Because, I sometimes would see people wait till the very last minute, and then, that adult child comes running in at the last minute, and that parent can't express it anymore. And it's really hard to watch.
Yeah.
And so I learned that lesson. I think I also learned, like, find what you love and pursue it, and don't let things hold you back. And to really entertain that. One of my residents really taught me that everyone's an artist and you need to embrace your inner artist. And for me, I don't claim to be an artist, but that always struck home to me, that deep inside of us all, there's something that's creative.
Yeah, we can be an artist of our own life.
Exactly. Yeah.
And that can look a lot of different ways.
Yeah. And she used to tell me that all the time, but you are an artist. Be humble and be kind and be open to the communication that's coming at you. And to really look at the end of life, as difficult as it is, as much as you can, to look at it as some kind of a celebration as well.
Absolutely.
And
of a life well lived.
Absolutely.
Yeah. I heard a quote the other day that, it's not only a physical event, it's also a metaphysical event. And there's this piece of like helping someone to, move into that next place.
Absolutely.
After doing this big learning here on planet Earth. It's hard.
It is hard. Yeah. And I really carry a lot of the experiences of my life along with me in this journey. I sometimes feel like, it could weigh a person down to see thousands and thousands of people pass away. But I also think there's just a little piece, and I have a faith that, those people are celebrating and cheering me on, and, that I carry that with me as well.
I love that. Yeah. So here's another question that I thought of for you. How do you take care of yourself so that, because you are such a giver, how do you give to your own self?
Well, I haven't always been very good about that. I have spent a lot of my life really kind of deep in challenges. And, I was a single mom of 3 for a long time. And, it's hard to take care of yourself when you're a single mom. But I've learned now, just especially in the last 4 or 5 years, I've really learned to spend time outside, spend time with friends, be active. I love sports. I mean, I ride bikes and motorcycles, and I paddleboard, and I swim, and ride snowmobiles and cross country ski. And the Methow is great because it gives us 4 seasons, and so I try to take advantage of all 4 seasons and do different things. But spending time with my family, traveling. I go in lots of little short jaunts. I don't get away to big fancy places, but I I enjoy that kind of time as well.
Yeah.
And I have a really strong faith, and that kind of keeps me stable and sane. Yeah. And just kind of keeps me centered.
Yeah, that's wonderful. I know I need to remember to try to get out more. Sometimes
it's hard. It's been hard in the last 2 years.
Yeah, I don't know why. This summer has been so fantastic, but it's still.
Yeah.
I try to get in the river, even if it's just for a few minutes in the day. It does something. It's just like.
Yeah, my husband loves to go to the river, and so does our dog. So every day, that's the deal. He comes home, the dog sits at the door and waits for us, and then we have to go to the river. So
perfect.
Almost every day, and I hate the cold water.
It's so enlivening.
Well, I know. I'm the one standing there going, "Ooh, it's cold."
I know, me too. I usually have to just dive straight in, but I'm trying to train myself. I read how good it is for you, that cold water. It is enlivening.
It is.
That is for sure.
It is true.
It wakes up every cell. And there's, the biggest part of the brain is actually like taken up with all the skin receptors. So it does something good in your brain.
Yeah. And you can feel it if you can just be brave enough to get in there.
Oh, yeah. Okay. Thank you, listeners, for dealing with that jet sound there and all the other technical difficulties that are probably happening on this recording we don't even know about. So, yeah, I wanted to talk a little bit about, grief and loss, because this is a part of life. Mm-hmm. I heard a really good quote. Love is the price that we pay. No, grief is the price that we pay for love.
Yeah.
And I definitely feel like that is so true. And so just for us in the community, what are some ways that we can show up for people who are in that really tender grieving place?
Yeah.
And what are some things to avoid or not to say in your experience? And because you probably receive a lot of feedback. You have your own personal experience, but then also feedback from other people. Because I think a lot of times we're very discomfort averse in our culture, and we don't want to say or do the wrong thing. But sometimes it can either bump us to do nothing at all, or conversely, people really can sometimes say really insensitive things, or things that seem helpful but really aren't.
Exactly. Yeah, I think the things that I most respect is when people are talking about grief and loss, and especially when they're talking to someone who's grieving, is really just to show up as your authentic self. Set yourself aside and just show up for the person. And sometimes that means don't talk. It means just be there. A hug, go get them a cup of coffee, hold their hand. We're a very talkative people. Humans are talkative. And sometimes the words get in the way and don't let people grieve. You don't always have to fill that space. And, you know, in my own experience, I had a lot of people who would call and say, I really want to show up. I'm really uncomfortable. And I'd say, you know, that's okay. A phone call is great. Just knowing that you're thinking of us is really, really helpful. And then I'd run into them in the grocery store. And I think the grocery stores are a great place to practice. And you'd see you'll see on people's face, I don't know what to do. Should I say hello? Should I go the other way? And I would say, just pat me on the shoulder as you walk by. I know what you mean. I don't have to have your words. You don't have to say anything. And I think, you know, sometimes that's all we need. Is we just need to know that someone else knows how we feel or knows we're hurting, and words don't really matter. I think, you know, the flip side of that is that when people are anxious and they're nervous and they're stressed because I should say something, so they say those things like, oh, but they're in a better place.
Right.
Or, you know, oh, God needed them. And it's like, those are the kinds of comments that are not helpful.
Yeah.
Because when you're a grieving person, it's like, there's no other place than here that person needs to be.
Yeah.
And, you know.
Yeah. Or like, oh, you're never given more than you can handle. Or
Yeah.
something like that.
Yeah, right.
Yeah.
Let me tell you my story.
You know, that's not really helping me right now. You know,
Exactly.
And I love that. That's so true. Because I think even though I have been on both sides of the experience, I too need that reminder that it's like just that touch, you know,
contact.
And just, And sometimes what I'll say now is like, I'm thinking about you.
Yeah,
you know,
exactly.
Like you're in my,
yeah.
Or I might just even go
that,
like that, you know, like, I'm
Yeah.
carrying you.
People just need to know that somebody can acknowledge what they're going through. And I think that's the other thing that I've learned is that everybody carries grief. It may not be about the same thing.
Yeah.
It's not for me to judge that their grief isn't the same as my grief.
Yeah.
You know, there's those stories going around like you never know the lady yelling at the cashier what they're going through. And it's true. You know, that much of the time people are grieving.
Yeah.
And they have no way to express it because it's invisible. People don't know what's going on.
Yeah.
And so, you know, just that, here you go first in line, or you're $1 short, let me hand you $5, you know, just being there for people can really take away a lot of that grief and let them know that they're not alone.
Right. Instead of, turning around and getting mad, angry back or something, saying, wow, maybe you're having a really hard time. And that's what's going on.
Yeah.
And giving people, some latitude and compassion.
Yeah.
I think, that's a really good point about, most of my life has wanted to fix, right? And it's just like, it's just not the time.
Yeah, because when you're grieving, you also can't accept everything.
Right.
So you can't take in what somebody's trying to help you fix because it's not time for you to fix it yet. You just have to wade through the muck for as long as you have to wade through it. And
Yeah.
there's no fixing it, but there is acknowledging it.
Right.
I do have one fix that I learned. And this was a hard lesson for me because I grew up as a person that you just do what you have to do. And you just put your blinders on and get it done.
Mm-hmm.
But when people, this is what I learned. When people offer to help when you're grieving, accept it. And if you don't know what to give them to do, here's my tip. Send them to the grocery store for toilet paper because everybody needs it. And you might have a house full of people. But people offer to do something because they don't know what else to do.
Mm-hmm.
But when we rebuke them, which many people do, myself included,
Right.
we're turning away their gift.
Right.
And so we're setting them up
Right.
for feeling uncomfortable with what to do.
Right.
So, let them go get coffee. Let them go make food. Let them run to the store for you. Let them babysit your child. Whatever it might be.
Yeah.
It doesn't have to be big.
Right.
But it is a gift they're trying to give.
And it does help to carry us through.
It does.
Because it's really exhausting.
Yeah.
When you lose someone.
It is. Yeah.
It's incredibly exhausting. Well, yeah, thank you for that answer, for that thoughtful answer. And that really is striking that chord of truth in me. Switching gears a little bit, I am wanting everyone and my own self, I'm always learning more about the Palliative Care Initiative and where it's been and where it is now and where it's going. And so if you could just talk a little bit about what it means for our valley and what is palliative care.
Yeah. So palliative care is a relatively new part of medicine. And it's a concept that there's a lot that happens between, for instance, the diagnosis of something that's chronic or serious and that movement towards end-of-life care. There's a lot that happens. And so when I was working at Jamie's Place, one of the things that I found that I loved the most was when a patient, okay, I don't want to say that sentence that way. When a patient was transitioning from a level of stable health to some instability, and we're calling families and telling them, I think now's a good time for you to come. We need to talk about all of this, and helping families understand, that this patient is in transition. I discovered that was palliative care. And it became one of my favorite parts of the job because what I could see is the stress level would dissipate. People would feel more in control by knowing the answers and the things that we could do and the things we might not be able to do and making plans. And so when I left at Jamie's Place, I decided to go into palliative care. And in 2018, kind of connected with Raleigh Bowden and her team that developed this palliative care initiative. Sorry, I keep scooting out of the screen. I apologize. I didn't know I wiggle so much.
I know. Let's take a little movement break. Okay, you met Raleigh.
Yeah, so I've known Raleigh. Raleigh and I have known each other for many, many years. We've done a lot of community education, particularly in the realm of end-of-life care and death and dying. And we used to put on, a long time ago, we used to put on events over at Blackbirds and talk about end of life. And so we've known each other for a very long time, but she really got interested in palliative care. And so I made that transition over to palliative care. So one of the questions that I'll dispel really quick is that hospice and palliative care are not the same thing.
Right.
So hospice is a program that's really designed for people with a very limited life expectancy in the last 6 months or less. And it's geared towards supporting families and helping them make decisions about how that's going to go, symptom management, making plans, those kinds of things. I did hospice for 10 years. I loved hospice. Palliative care is really designed for people who have a chronic or a serious illness diagnosis. For instance, end-stage heart failure or renal failure, chronic lung disease, cancer, neurological disorders like ALS, that we know that there's a progression. We just don't know what that progression might be. Palliative care allows people to get treatment. So people who are seeing oncology and receiving chemotherapy and radiation, they can receive palliative care. They can't receive hospice.
Oh yeah, I did push record.
Okay.
I just had a little panic.
Oh, that's funny.
Right.
Yeah.
So it's the pre.
Yeah. So yeah, I mean, I have consulted with patients. I worked for Confluence Health for 5 years as a palliative care nurse. And I would often see patients like as they were getting the diagnosis.
Right.
And partly that was because of the high stress levels and anxiety and fear. And they were kind of feeling out of control. And so I would actually visit with them that day. And then other times it was that chemotherapy wasn't going well and they had to make decisions about what their next, decision would be, surgery or more chemo or radiation. And that can be very stressful, obviously, to people. Yeah. And so being able to just be in there, get to know them, kind of walk them through the options, big conversations like, what are your goals? What are you hoping for?
Yeah.
And it could be, I just want to live until my daughter graduates from high school. And then we would work on that. What's it going to take to do that? And then what happens if we can't? How are we going to manage that?
Right.
So palliative care is a lot of talking. It's a lot of communicating with patients. Yeah. But we also do things like symptom management, help with pain and anxiety and nausea and, bowel and bladder function, and what is kidney dialysis, and we do all kinds of different conversations.
Well, and it's so important too, because so much of our medical system is specialized. And so it seems like palliative care is that glue that holds a lot of it together.
Yeah, that's what we're hoping for.
Right.
Yeah. So in 2019, we got a grant to kind of start funding the initiation of an actual service. And our goal is for palliative care is to be countywide.
Right.
We are in Okanagan County. We are the highest utilizer of ICU in Wenatchee out of all the other communities. It's Okanagan County. And it's because people wait, or it's so far, or they can't get there.
Interesting.
And so we really want to keep people out of ICUs, keep people out of the hospital if we can help it. So I think there's a lot of space for palliative care to kind of help people make a difference. And so we initiated it initially with part-time people, and then created more of a team, and that team continues to grow. Our referrals continue to grow. Our goal is to be available for any patient from any service. So we work with Confluence, we work with Family Health Center, we work with Mid-Valley. We get patients from Tonasket, Oroville, Brewster, Bridgeport, and obviously the Metro, as we're centered here. Most of us work and live here. But it's a service that's focused on the needs of the patient.
Right.
But also the needs of the family and the support system.
Right.
So we talk about what their needs are and what resources are available for them. So it's kind of a bigger, more expansive kind of way of looking at people and helping people make decisions.
Yeah, because that is all a very big part of the picture for the patient.
Yeah, and healthcare is really hard to navigate.
Yeah, just very short appointments.
Yeah.
And
often long time between. So they get a
Right.
diagnosis and they get a plan, but then they might not see a doctor for a month and a half. And what do you do in the meantime? And they don't know how to deal with, they're taking pain pills, but they don't think about the GI complications. And
Right.
so it just gives them one more person that,
Yeah.
we do a lot of phone calls trying to help people, those
Yeah.
things.
Well, it's wonderful. Yeah, anything else? Where's the vision for it to go, I guess, the initiative? What happens, I guess, at the end of the grant?
Yeah, so we got one grant that closed. It was a planning grant for 1 year.
Mm-hmm.
And then we also had a 3-year grant that was more for developing the organization and all of that. And now we also have a 4-year HRSA grant, which we have 3 years left on that.
Oh, good.
And in the meantime, we partnered with family health centers. And so that is our palliative care home, although most of us work from home because we travel. We see patients all over. But that allows us to have customer support, good scheduling, electronic medical records that speak to all the other organizations. And then it also allows us to bill. So we're now billing for some of our services. We work with Medicaid and Medicare. We're on a Department of Health palliative care initiative with the state, who's trying to really bring in palliative care in a bigger way into rural areas. And one of their initiatives is to get palliative care approved by Medicaid in the state of Washington, so that Medicaid patients have this as a benefit.
Oh, that's great.
Yeah. And so we're hopeful that in the next year or two that will move through the Department of Health. So we work on lots of different, we're working to advocate for that. And,
there's a lot of roots and branches.
There's a lot of roots and branches.
Yeah, and just thinking about that, Okanagan County has the highest rate of ICU users in Wenatchee. I'm just curious, is that just lack of planning, or is
No, it's a combination of a lot of the demographics. So we have, and I wish I had the statistics, but our population is older by quite a bit than most counties in the state.
Right.
Our population is more ill, has a lot of higher chronic and serious illness populations than the rest of the state. And we also have we have the largest, the Colville Confederated Tribe is the largest reservation in the state of Washington. So we have, that demographic, as well as we have the Hispanic Latinx population.
Right.
And there, the medical care issues and just health statistic issues.
Language barriers. Cultural barriers. And so you are serving.
We're working to serve those populations as well. We've got a really good, strong partnership with the Colville Confederated Tribes and Encompass Home Health and Hospice. So that when we get a patient, oftentimes all 3 organizations already know about the patient, but we can help the transitions. And if they live on the reservation land, I can get them more resources from a different place. And
that's great.
So that's one of the things that we're really trying to build in palliative care, is those relationships with all the different organizations.
Right.
So that we can get references and resources that, we are a people organization, but there's a lot of resources out there for people.
Absolutely.
Yeah.
And it can be very tricky to try to figure out what resources are actually available.
Oh, I mean,
we find that here at Met-How at Home a lot.
Absolutely.
And you have to be like, reading a lot of different emails coming from a lot of different organizations, and you'll be like, what? They exist?
Exactly. I didn't know you could do that.
I didn't know that was happening.
Yeah.
And so then, just trying to gather those jewels and gems.
Exactly. So for instance, we had, if you've been around the community for any length of time, there's always been a question about durable medical equipment.
Right.
And at one time, you could go to Jamie's place because they had a high school project that built a little shed for us there, and here at the community center, and
The Cove
the
had
Cove,
some,
and yeah, and people had it in their garage and stuffed in corners and everything. And so one of the things that the palliative care group did is we did a mini grant and hired someone and created a system where now we'll have a donation kind of system for people to go and get medical equipment, whatever's available. We don't
Right.
purchase it, but
right.
continuing to build resources.
I was just talking with Justin, who's also on your
Mhm.
team, and because I was thinking, ooh, Justin, could you do a program, about the DME
Uh-huh.
and closet and
Yeah.
how to access it and what's there
That'd be a
and
great
how to
one.
utilize it. And
Yeah.
he said there was an article coming out in the paper.
Wonderful.
So,
Yeah.
but hopefully we'll do a little Zoom on it
Yeah.
too, because it's good to have things recorded and
Yeah, absolutely.
accessible. Who else then is on, like, if somebody listening here,
Mhm.
I got a recent diagnosis and they didn't recommend the palliative care, how do they get in touch with you?
Yeah, probably the easiest way would be to call family health centers and ask for a palliative care team member,
Okay.
because we now have a whole directory of phone numbers. If you know me and you have my phone number, you're welcome to call me.
Be careful.
I know. But family health centers is our home, and
Right.
so we
Okay,
are
great.
encouraging. We're working on developing marketing tools that will have all those phone numbers and
Mhm.
ways to access us.
Great.
Yeah.
Thank you. Thank you
Mhm.
for doing this important work.
Yeah.
So yeah, another part of the palliative care initiative has been the advanced care planning piece that Met How at Home and palliative care have worked together on for the last couple of years. And so I'd love to hear your perspective on, what about that process do you think is important, and
Yeah.
why is it an important process?
Thank you. That's a really good question. So advanced care planning is really thinking about future health needs, and both planned and unplanned. Accidents happen,
Yeah.
disease happened. So making those decisions. And then the second part of it is really having discussions with people who could make those decisions for you if you could not.
Right.
So I always use the example of, you're driving, over one of the mountain passes and you get in a car accident and you bump your head. And a head injury is a serious thing, and it can be very short. It could be serious and long. But when you arrive at a hospital and you can't speak for yourself, the first thing that hospital staff try to do is figure out who is that decision maker for you.
Right.
And a lot of people say, oh, well, that's easy. It's my this person or it's my that person. But in the state of Washington, there is a law that dictates who that person is. And oftentimes it is either a bigger group than you think, or it's not the person that you want. So you might be married, but you feel like that would be a burden for your spouse, so you wouldn't choose that person, but that's automatically who it's going to default to.
Right.
So being able to have those conversations, and when you're healthy, making a decision and putting it in writing so that people know who that is.
Mm-hmm.
So I always tell people, like, they'll say, oh, my children, or one of my children. Well, how many children do you have? I have 5. Okay, well, in the state of Washington, if you haven't designated your one, all 5 have to make the decision, and all 5 have to agree.
Right.
And then you get in, well, I haven't seen this child for 3 years. I'm not sure where. Well, they're going to spend time looking. And that you don't want to slow that process down if you can help it.
Right.
So there are important reasons for doing it. And people think, oh, it's an end of life thing. No, when you're 16 and you get a driver's license, you probably ought to be talking about it with your children, because kids are the highest risk for serious car accidents.
Yeah.
which, parents are automatically default as a decision maker, but it's a good thing to actually talk to children about.
Yeah.
And make a plan.
Yeah.
It just speeds the process along, and kids at 16, 18, 21, they have an opinion about what they would want in their lives. So
yeah,
it's a good
absolutely.
decision for everyone to make.
And I think too, there's a piece that I bring, into the thought process and conversation about what you would want to have done to your physical being if you do die suddenly, because a lot of times you won't have agreement.
Exactly.
If you don't ever have that conversation,
Yeah.
then you might not get any form of
I have
agreement.
a wonderful story about a couple who had been married for, 50, 60 years, maybe longer. They knew each other really, really well. They were a beautiful couple, and they wanted to do advanced care planning. And so I had gone out to their house, and we were having this great discussion, and they were just in agreement. Everything was in agreement. Until I got to the question about burial versus cremation. And he said one thing, and she looked at him and said, "What?" And he said, "Well, these are all the reasons." She's like, "I don't agree." And I said, "Okay, so we need to stop and you guys need to sit with your family and you need to have a conversation about it."
Right.
Because clearly there was some philosophical and emotional and spiritual differences in their decisions.
Right.
He did not know that about her.
Yeah, it happens.
It does. And so it set up a beautiful follow-up advanced care planning session with them, because they really talked through it. And they talked with their children and their grandchildren. And so everyone in the family got to weigh in and talk about it. And I wasn't there, but it was apparently a very beautiful conversation.
And the other piece is that there are other options that are constantly, arising.
Absolutely.
And it's good to understand what options we have here and what we don't have here. And if you want a different option, like having natural burial, because for me, I'd rather just be like buried in the ground with some plants, buried right on me. I need to go back into the life family. That's my whole thing, right? But that's not an option here.
Right.
So it's an interesting thing. 48 out of 50 states allow you to be buried on your own property.
Oh, wow.
But not Washington.
Interesting.
So.
Yeah.
Yeah. Thank you for all your work. I've sat with Sheila at the table before. It's always, we always are having very interesting conversations.
Exactly. Yeah.
About these things.
Yeah. It doesn't have to be a sad conversation. It can be very enlivened and fun. And
I know. It's a place for a lot of creativity,
Absolutely.
and I do think that I always encourage people too, because sometimes people will be like, I don't want a funeral. I don't want anything. But that's really, like, I think because people have ideas on maybe what that needs to be, but it's so broad. You can ask for a lot of different things. It's important for your family to be able to really,
absolutely,
I think, celebrate your life and honor you in different ways.
Yeah.
And there's really some beautiful ways to do that.
Yeah. Absolutely.
Not only for ourselves who are left here, but also, for our loved ones.
Yeah.
Too.
And it really is for them. They need to be able to have some way of processing information.
Yeah. Okay. One thing we have coming up at Met How at Home, thanks to Sheila, is a 4-week workshop on how to care and attend to our people in our lives who have dementia, or maybe could it be for if you have early stage of dementia as well?
Well, I think a lot of people, dementia is one of the fastest growing healthcare issues in the world.
Yeah.
It's currently on the rise. Right now, there's 6 million Americans struggling with dementia of some form or another. Those 6 million Americans is really important, But even more devastating is the 11 million people who are taking care of those 6 million.
Right.
So we're all touched by dementia in some way.
Yeah.
And much of my work at Jamie's Place included dementia. And because when a person, especially like a solo elder who's lost their partner, is living home alone and they get dementia, there is a point when they become not safe. And they either have to have caregivers come in 24/7 or they have to move somewhere. And so the thing that I saw was there's so much lack of information or misinformation about what dementia is and how to communicate.
Right.
And so it has been a passion of mine to teach about dementia and ways to manage behaviors, ways to provide activities, ways to communicate. What is the stages of dementia? What's the difference between dementia and Alzheimer's and everything else? It's kind of a word salad and people don't understand. And so, yeah, I'm really happy to partner with Met How at Home and be able to do a series of classes for people.
Yeah, thank you so much. Yeah, and that's also thanks to the palliative care.
Yeah, exactly.
Thank you, HRSA.
That's right.
So that's going to be every Thursday at the Grange from 3 to 4:30 in October.
In October. Yeah.
All right. And we'll be sending more information out and how to register for that.
And I just will also additionally say, although we're not ready to roll it out, I also have a partnership with Jamie's Place. Raina Clark, the administrator there, and I.
So amazing.
Yeah, have done this course called Virtual Dementia Training, where at some point we'll be able to roll out to allow people to sort of experience for themselves in a very short period of time what it feels like to have dementia and why their loved ones act or behave the way in which they do based on the way the brain processes information. It's pretty amazing. We don't know when we'll get that rolled out, but
that's exciting.
Yeah.
So much in life you don't understand what's going into something or what someone is experiencing until we experience it ourselves. So
exactly.
That's a great educational tool.
Yeah.
A couple more questions. Thanks for those of you who are still with us. It's so interesting for me. I love these conversations because I always think I know, a lot about a person, and I always learn more, and I love that. Just what are some of the trends that you've been seeing in the Valley through the years?
Yeah, I thought about this, and I think this was a harder question for me to answer because I've spent so much time sort of focused on the projects in which I work. But some of the things I do see are the availability and opportunities for grants and opportunities to grow new programs, especially in rural communities. There is more of a focus.
That's so true.
Yeah. I think there's a rising awareness of aging in our fragile community, housing for our elderly. They're being priced out of the community and this is their home. And I also think there's a huge growth opportunity in volunteering across the spectrum in just about any kind of avenue. And this has always been a very giving community, and volunteerism has always been high, but I think it's even getting higher. And certainly meeting lots of people's different needs to volunteer. I think there's a growing awareness of the diversity and equity issues, especially in healthcare.
Yeah.
Who gets care and who doesn't, and how they function throughout the system. And my hope is that more and more resources come to rural areas to help. I think we're at a certain disadvantage when it comes to healthcare in particular.
Yeah. Just being far from appointment, from specialists is
exactly
a big thing.
Yeah.
And I don't know if that can age. But
Yeah, I mean, I think it's a choice that we make to live in
Yeah.
a place where it's separate, but it also is an equity issue. You know, some people can up and go to Seattle and spend time at specialists, and some people can't.
yeah,
And, you know, but with telehealth, I hope that begins to balance that out a
Yeah.
bit. Palliative care does a lot with telehealth.
absolutely.
COVID really just jump-started that, and there's a trend, at least what I saw at Confluence Health, for a lot of, especially the elders, who appreciated not having to go into an office.
Yeah. And that's something that I will say as well is, Met How at Home can
Mhm.
help people who are confused about how to use
Mhm.
telehealth, how to access that. And
Yeah. Okay, I'll sign up for that because I'm often confused.
Yeah. we'll send Pete
Yeah.
Spear over
There
to you.
go.
Oh no, Peter Bauer. What am I saying? Sorry, Pete Spear. Yeah, what changes would you like to see in some of the services available here? You started to kind of brush into that.
Yeah.
But
Well, when I think of here, I think of
I'm gonna do
two things. Yeah, sorry. Keep wiggling. I apologize.
that's okay.
I really think of here as not just our local area, but also
Right.
the whole state of Washington and the whole U.S. Because what I really would love to see is that there's a change in attitude about the way healthcare is delivered, and that this putting people first, paying for the services that people really need, and palliative care is just one simple, and I know that's kind of self-indulgent because that's my program, but if palliative care could keep people out of hospitals and keep people out of ICUs, it would save so much money and suffering. But that is a national policy change. That is getting everybody to understand that there is a different way. It's conversations. It's rewarding people for, taking care of themselves when they have these chronic and serious illnesses, as well as anything else. But and then also rewarding organizations that do things that are high performance, good outcomes, good quality care. I think we have these small hospitals that do really, really good work. Would love to see them get rewarded for that.
Mm-hmm.
We can't compete on the level of service with the big hospitals, but they get rewarded for that. And so I'd love to see that shift a little bit.
Yeah, great point.
Yeah. I think finding ways to bring care more to people wherever they are, to utilize really good medication management, really good symptom management, like meet them before they get sick and, are practically in a coma from their sepsis because they couldn't get to a doctor or whatever. Using community health workers.
Right.
Create a population of people that can visit with people and really see how they really are in real time.
Mm-hmm.
Versus making people wait for 3 months to get into a doctor.
Right. Family health centers, I'm so impressed with a lot of the shifts and the expansion, at family health centers of the community health workers and bringing on the palliative care. And
I think that family health centers is really focused on being that community-based home, medical home for people.
Mm-hmm.
And if you're looking that way, where this is your home, then they really are focusing on how to keep people well, not how to heal when they're sick.
Right.
And I think that is a really strong focus for the future. We know that, these big diseases, cancer and heart failure, they're not going to go away. But there's a lot of things that can be done to maintain people and inform people on how to best take care of themselves.
Yeah.
And now with telehealth, if there were funding, we can get people, electronic blood pressure cuffs that they just put it on in the morning and it sends it to their doctor. They can do pacemaker checks at home. They can check their urine for urinary tract infections. They can, send their diabetes thing right directly to the doctor. I mean, that keeps a lot of people out of the system if we do it that way.
Right.
But it takes a nation to make that's the priority.
Right.
Is to keep people healthier.
I love that. Yeah, one of the fall prevention, that's the other aspect of our module this September, October. And, one of the programs that we've been looking into is coming out of Johns Hopkins called Capable. And so if somebody has a fall, then there's this team that goes in because they've researched all sorts of different things to try to figure out, like, how do you stop that cycle? Because it's so pernicious once it gets going, right? It can just really signal like a loss of quality of life for people.
Yeah.
And so they send in an RN who's helping with medication management and some of those health aspects, and then occupational therapist taking a look at the home and strength and balance and, what's needed and that sort of realm. And then also a handyman.
Which is
so making the home modifications, right?
Yeah.
But Medicare won't cover it.
I know.
Because it's under preventive. Like,
Right.
why would preventive not be covered?
I know.
But it's part of that national conversation.
That's right. They could spend $500 to put it in grab bars beside someone's commode and their shower and prevent like a $100,000 surgical ICU experience for someone. It's a national conversation. I would love to.
And it's a local conversation, that we're working on. And that's part of another HRSA planning grant that Raleigh Bowden helped to get with Jamie's place. And that's going to be one piece of it. And so,
And I would say the other big, I mean, this is one of my bigger sections here in my little notes, but the other thing that I think really has to shift is the support of people who are caregivers.
Absolutely.
To pay them living wages, to give them resources. I mean, many caregivers are living without wages. They're living without health insurance. They're trying to juggle a family and then go over here and care for someone, or I think, and again, the Metao has a lot of people who are very creative and are working on lots of solutions. And it is a bigger issue as well.
Absolutely. Once again, Medicare, Medicaid is paying $15 an hour for a really difficult, that's a very demanding work.
Yeah.
That should be compensated for the importance that it's fulfilling in our society.
Absolutely.
So,
well, I think the numbers, I mean, it's in the billions if you had to pay for all the private caregiving that's going on in our nation. It's in the billions. And, many of those people feel like they would do the job irregardless, but boy, it'd be nice to support them while they give up their work and time with their families.
And there is some compensation if the patient is on Medicaid for families.
Yeah.
I believe.
There is. It's complicated. It's not super easy.
Yeah, exactly.
They have to get a class and they have to get that through that first. And
is it only through Medicaid?
It's only through Medicaid.
That's what I thought. Okay. Oh, so many things to learn. Sheila, thank you so much for just, all of your work. And I love that you're elevating this piece, really delineating like patient-centered care as being the wave of the future. And I think it's a distinction that people might not even articulate,
right.
in their mind, but it is so true.
I think we're the captains of our own ship, and we don't always listen. We listen to the outside noises, but we often know what's best for us and how we would want to live if we can make that decision. So yeah, that's my 15-year-old self-advice is person-centered care.
Yeah, absolutely.
And I really appreciate the opportunity to share information and spend time with you. And
Yeah, thanks so much for this hour, and thanks to our watchers who need information and just learned a lot, I think,
yeah,
in this conversation. So
yeah. Usually these conversations lead to other conversations. So.
exactly. It's not like a straight line, when you get a diagnosis. There's
Right.
no straight line.
There is no straight line. Yeah.
And just knowing the importance to advocate for yourself
Mhm.
and to talk to somebody who
Yeah.
will be able to advocate for you if you can't speak for your own self within the medical system.
Yep.
And
Have the conversation.
yeah. Great. Okay, here we go. Turning the recording off. Have a great day, everybody out there. If I can find my cursor. Okay.